Okay, let's untack this. Today, we're taking a deep dive into an absolutely crucial topic, thyroid disorders. Think of that small but mighty gland in your neck. The thyroid, often overlooked, yet it wields profound control over cellular energy. It impacts nearly every system in your body. We've got a fantastic stack of sources for this deep dive, pulling from Margaret A. Fitzgerald's 2024 workbook. It really lays out the assessment, diagnosis, and treatment of these, well, incredibly common conditions. Our mission today is to cut through the complexity, get to the most important nuggets of knowledge. You'll walk away with a much clearer picture of what the thyroid does, what happens when it goes wrong, how it's diagnosed, and what treatment truly looks like. Plus, we'll uncover some surprising details, insights along the way that might just, change how you think about everyday health complaints.
It's truly fascinating, isn't it? Just how profoundly these tiny glands influence your entire system. They really are, in essence, a master regulator.
A master regulator, I like that.
Yeah, of cellular energy, impacting everything from your mood and energy levels to metabolism, even your heart rate.
Yeah.
It's astonishing how much they orchestrate.
It really is. To truly appreciate this master gland, we need to understand its fundamental role. So what exactly is the thyroid's core job?
Well, at its most basic level, the primary function is producing two key hormones, thyroxine, which we often call T4, and triiodothyronin, or T3.
T4 and T3. Okay.
Think of these not just as hormones, but as tiny catalysts, kind of like spark plugs for every single cell in your body. They directly influence the release of energy and, by extension, the function and health of, well, every cell.
Wow. So when these energy catalysts are off, the ripple effect is huge, immense.
Right.
What happens to the body when that energy release starts to lag? What does that look like for someone?
Right. When that cellular energy release slows down, we see what's called hypothyroidism. It's essentially your body running in slow motion.
Slow motion. Okay.
And this is the most common thyroid disorder we see in primary care. It tends to be more prevalent in women over 50. The key insight here isn't just what the symptoms are, but how easily they can be dismissed.
Dismissed? How so?
It's just getting older, or stress, or simply being tired,
Yeah, that makes sense, which is why understanding the clues is so vital. Our sources offer a pretty handy mnemonic. Helps us quickly recognize the wide array of symptoms for hypothyroidism. Mom's so tired. Let's break that down. M, that stands for memory loss.
Cognitive changes.
The first O is for obesity. Though it's typically modest weight gain, right? Often less than 10 pounds, mostly fluid.
Exactly. Mostly fluid retention, not massive weight gain usually.
Okay. The second M is menorrhagia, which means unusually heavy or prolonged periods.
Correct.
Then the first S is for slowness, both mentally and physically, like feeling sluggish, brain fog.
That's right. Everything just feels slow.
The second O is for onset gradual, meaning these symptoms creep up over time, makes them harder to pinpoint.
Very true. It's insidious sometimes.
T stands for tiredness, which is, well, pretty self-explanatory. Profound fatigue.
A really deep fatigue, yes.
I is for intolerance to cold, because your body isn't making enough heat.
Right. The internal thermostat is turned down.
R represents raised blood pressure, usually modestly. E signifies energy levels falling.
Consistent with the tiredness.
And D is for depression. And also, this is interesting, a delayed relaxation phase of reflexes, especially the patellar and Achilles.
Yes, that's a classic physical sign we look for. Reflexes hang a bit.
But the really good news, and this is crucial, is that all these signs and symptoms, they're completely reversible with proper treatment.
That reversibility is absolutely key. And understanding why these symptoms appear comes directly from the underlying pathophysiology. So the most common cause of hypothyroidism by far is Hashimoto thyroiditis.
Hashimoto's, yeah.
It's an autoimmune condition. Your body essentially attacks its own thyroid, gradually destroying its ability to produce hormones.
Wow.
And the critical insight here is that by the time many people are diagnosed, significant thyroid damage has already occurred.
So it highlights the insidious nature of these autoimmune conditions and why maybe early nuanced testing is vital?
Exactly. Other causes include post-radioactive iodine treatment, maybe after Graves' disease or thyroid cancer. We actually induce hypothyroidism sometimes to resolve the initial issue.
Right.
And certain medications can interfere too, things like lithium, amiodarone, interferon.
Okay, so if hypothyroidism is like hitting the brakes on your body's energy, what happens when the accelerator gets stuck down? When the system is running too hot?
That would be hyperthyroidism, excessive cellular energy release. It's the body in overdrive.
Overdrive, okay.
This condition is most often found in women aged, say, 30 to 50 years. The challenge here is that symptoms like anxiety or unexplained weight loss can easily be chalked up to other things.
Right, makes diagnosis tricky without the full picture.
Precisely.
And just like with hyperthyroidism, there's a mnemonic to help recognize the symptoms. This time it's sweating. So S is for sweating.
Makes sense. Body's running hot.
W is weight loss, typically around 10 pounds, affecting muscle and fat, often despite eating more.
Yes, metabolism is just burning through everything.
Yeah.
Even with an increased appetite.
E is for emotional quality, like a racing mind, memory alteration, maybe heightened anxiety.
Very much so. Feeling wired, on edge.
A is for appetite increased, which we just mentioned, confusing when you're losing weight.
It really is.
T means tremor and tachycardia. That's a rapid heart rate.
Yes, a very common noticeable symptom. The shakes in a pounding heart.
P is for intolerance of heat. Makes sense. Also irregular menstruation and irritability.
The whole system is agitated.
N is for nervousness.
Goes along with the emotional willability and tremor.
And G covers goiter and enlarged thyroid gland and GI problems, like frequent loose stools.
Correct. More frequent low-volume stools are typical.
And again, crucially, these signs and symptoms are also reversible with proper treatment.
Absolutely. For hyperthyroidism, the most common cause is Graves' disease.
Graves. Like Hashimoto's, it's autoimmune.
Exactly. Also autoimmune. And you often see it alongside other autoimmune conditions like RA, lupus, vitiligo, celiac, type 1 diabetes.
Oh, okay.
Typical presentations include exsulfos, that characteristic bulging of the eyes, and often a goiter. But here's where it gets really interesting.
Okay.
In older adults, you might see an atypical or apathetic presentation of hyperthyroidism.
Apathetic, so less of the wired feeling.
Yes. It can often be coupled with new onset tachydysrhythmia, basically, an abnormally fast or irregular heart rhythm, like atrial fibrillation, AFib, where the heart's upper chambers beat erratically, and even heart failure. All without the classic overt symptoms like extreme nervousness.
Wow. That's a huge potential pitfall in diagnosis for older folks.
Yeah, absolutely is. Other causes include toxic adenoma. That's a benign but metabolically active thyroid nodule.
So a lump that's overproducing hormone.
Essentially, yes. Presents with typical hyperthyroid symptoms, a palpable mass on one side, but usually no exophthalmos, no bulging eyes.
Got it.
Then there's thyroiditis, usually transient, can be viral, autoimmune, postpartum, or drug-induced. It presents with milder hyperthyroidism, maybe some thyroid tenderness, but typically no exophthalmos.
Okay.
And similar to hypo, select medications like amiodarone again and interferon can also induce milder hyperthyroid symptoms, usually without goiter or exophthalmos.
So given all these varied symptoms, different causes, how do doctors start to figure out what's actually going on inside, distinguish between them? What's the starting point for the detective work?
Well, the single most reliable test, especially in an outpatient setting, is the thyroid-stimulating hormone, TSH.
TSH. Okay.
Its normal range is typically between 0.4 and 4.0 MIUL, give or take a little depending on the lab. The real power of TSH is its high sensitivity and specificity. If your TSH results are within normal limits, it strongly suggests thyroid disease has largely been ruled out.
So it's a great first screening tool?
Exactly. If we connect this to the bigger picture, TSH is your primary guide for initial screening. It reacts so sensitively to even small changes in actual thyroid hormone levels.
Okay, so TSH is our primary guide. But what if that guide points, in a direction that suggests something is off? What's the next piece of the puzzle?
That's when free T4 or free thyroxine comes into play.
Free T4.
This is the unbound, the metabolically active portion of T4, the part of the hormone actually doing the work in your cells.
The active part. Got it.
Its normal range is around 10 to 27 pMol. Again, lab ranges vary slightly. This test is used as a follow-up to confirm or support the diagnosis when that initial TSH is abnormal.
Makes sense. Are there other key tests?
We might also check the thyroid peroxidase antibody, or TPO-AB.
TPO antibodies.
Right. Normal is usually less than 35 IU/ml. This test helps detect autoimmune thyroid disease like Hashimoto's or Graves. It looks for antibodies attacking the thyroid.
So it helps pinpoint the cause sometimes.
Exactly. Other tests like total T4, total T3, free T3, reverse T3, they're rarely indicated.
Yeah.
Usually TSH and free T4 give us what we need.
Good to know. Keep it simple. So once diagnosed,
Hmm.
What's the game plan? How do you get the body back in balance? Let's start with hypothyroidism, low function. What's the treatment approach?
Okay, for untreated hypothyroidism, the primary intervention is prescribing levothyroxine. You might know the brand names,
Sure.
Synthroid or Lavoxy,
Yeah.
or just the generic form. It's essentially a bioidentical replacement hormone.
Yeah.
It gives your body the T4 it needs.
Oh, a direct replacement.
Precisely. The dosing, though, is incredibly precise. It's highly individualized, calculated carefully based on your body weight, age, other factors, which is why regular monitoring by your doctor is so crucial.
Where you can't just guess the dose.
Definitely not. Patients usually start to feel clinical improvement after about maybe a week of taking levothyroxine.
Yeah.
But here's a critical patient education point. For adherence and proper absorption, levothyroxine should always be taken with water. On an empty stomach, same time every day. Ideally, about 30 to 60 minutes before breakfast is common.
Empty stomach. Got it.
And crucially, it should not be taken within 2 hours of cations.
Cations, like,
Things like calcium, iron, aluminum, magnesium. Think supplements, antacids.
okay. Why is that?
It's due to a chelation effect. Those minerals can actually bind to the levothyroxine in your gut, prevent your body from absorbing it properly.
So you take the pill, but don't get the full benefit.
Exactly. It messes with the effective dose. Oh, and importantly, the T4-T3 porcine thyroid combination, sometimes sold as armor thyroid.
Yeah, I've heard of that.
It's generally not recommended by major endocrine societies like the ACE,
Why not?
mostly due to its variable pharmacokinetics.
Mm-hmm.
How the body processes it can be inconsistent, less predictable than levothyroxine.
Interesting. Consistency is key with hormone replacement.
Have-
Okay, that's a great insight. It's not just what you take, but how and when. Now, for hyperthyroidism, when the system is running too hot and needs to slow down, what's the approach there?
Right. For untreated hyperthyroidism or thyrotoxicosis, at the time of diagnosis, a beta-adrenergic antagonist is often used first.
Beta blockers.
Yes, like propranolol or Datalol, if they're not contraindicated for the patient. These help manage those immediate troubling symptoms like the rapid heart rate, the tachycardia, and the tremor. Buys some time.
Calms things down symptomatically.
Exactly. Then the primary treatment for the hyperthyroidism itself usually involves oral medications, like methimazole, brand name Tapazole, or PTU. These work by reducing the thyroid's production of thyroxine. They help the patient become euthyroid.
Euthyroid, meaning back to normal thyroid function.
Correct. Normal thyroid function. Now, once a patient is euthyroid from these antithyroid medications, radioactive iodine, or RAI, is a common next step.
Radioactive iodine, how does that work?
The thyroid gland naturally takes up iodine. So you give a radioactive form, it concentrates in the thyroid, and the radiation essentially destroys or ablates the overactive thyroid tissue.
So you quiet down the overactive thyroid permanently.
That's the goal,
Yeah.
which, of course, often results in subsequent hypothyroidism.
So you fix the too much problem, but then often need to treat the too little problem with levothyroxine.
Precisely. It's often seen as a more definitive, manageable, long-term solution than staying on antithyroid drugs indefinitely. But there's a crucial warning with methimazole and PTU use.
Okay.
There's a rare but serious risk of acute hepatic failure, liver failure, even in people without any pre-existing liver disease risk factors.
Wow, that's serious.
It is. And because of these complexities, the potential side effects, the treatment choices, hyperthyroidism, especially around diagnosis, is usually managed in conjunction with an endocrinology consultation.
Makes sense to involve a specialist.
Yes.
Okay, now, here's where it gets really interesting, as you said before. What happens when the TSH is elevated, but the free T4 is still normal? This is called subclinical hypothyroidism, right? It's kind of a gray area. Do we always treat it?
That's a great question, and it's a very common clinical scenario. In cases of subclinical hypothyroidism, recommended treatment with levothyroxine is generally advised if the TSH is over 5 MIUL, and there's also a presence of goiter, or those TPO antibodies we talked about.
Okay, so TSH5 plus goiter or antibodies.
Right. Or treatment is also often favored if the person has symptoms compatible with hypothyroidism, even if they're mild, or in specific situations like infertility, pregnancy, or if pregnancy is planned soon. Even subclinical thyroid issues can impact those.
Right, important for fertility and pregnancy.
Very important. The follow-up for these patients, if treated, is similar to those with overt full hypothyroidism. The insight here really is that not every slightly elevated PSH needs immediate jumping on with medication. It's about the whole picture, the context.
Connecting it to the broader clinical picture.
Exactly.
And you can really see how even small medication adjustments, or just changing the timing, like you mentioned with vacations, how much difference that can make. Our sources highlight that example of the 38-year-old woman on levothyroxine. Her TSH was just slightly elevated, 4.5, when the upper limit of normal was 4.0. She said she was taking it correctly, empty stomach, with water.
Mm-hmm.
But turns out she was taking it with her morning coffee, which can interfere with absorption, just like those minerals.
Yeah. Coffee is another common culprit for reducing absorption.
Just that little nuance can throw things off. It really matters for getting that energy balance right.
Absolutely. Details matter immensely in thyroid management.
Okay, switching gears slightly, what about those lumps or bumps people sometimes find in their neck? Or that pop up incidentally on other scans? Let's talk about thyroid nodules.
Okay. A thyroid nodule is simply a palpable thyroid mass. Typically needs to be greater than about 1 centimeter in diameter to be felt easily. It's important to understand this isn't a specific diagnosis itself, it's just a finding, a lump.
Just a finding, okay. Are they common, often cancerous?
They are relatively common, especially as people get older. But the risk of any particular thyroid nodule being malignant, meaning cancerous, is actually quite low, about 5%.
Only 5%. That's reassuring.
It is. And complicating things, the clinical presentation, how it looks and feels for benign and malignant thyroid lesions is typically the same.
So you can't tell just by feeling it if it's serious?
Not reliably, no. Which is why further investigation is often needed.
Okay. So this raises an important question. When should you or your doctor be more concerned about a thyroid nodule? What are the red flags?
Our sources list several findings that are considered more consistent with a malignant nodule. These include things like a history of head or neck irradiation, especially in childhood. The nodule being larger than 4 centimeters.
Size matters.
It can, yes. Also, if it feels very firm, hard even, and isn't tender on palpation, if it seems relatively fixed, doesn't move easily when you swallow.
Fixed in place.
Right. Persistent non-tender lymph nodes in the neck nearby. Dysphonia changes in your voice, like persistent hoarseness.
Voice changes. Okay.
And, though rarer, hemoptysis, which is coughing up blood.
Got it. So those are signs that warrant more urgent investigation.
Definitely. In primary care, the role of the nurse practitioner or physician is to initiate the right diagnostic tests and evaluation when a nodule is found. This usually involves referring for further study. Often imaging, like a thyroid ultrasound, is the first step. And frequently that leads to a recommendation for a lesion biopsy, usually a fine needle aspiration, which is crucial for determining if it's benign or malignant.
So primary care spots it, starts the workup, then refers for more specialized tests like biopsy if needed.
That's the typical pathway, yes.
We've covered a lot of clinical details. Maybe let's connect it to a real-world scenario, make it more concrete. Our sources present the case of Mrs. Lange, a 79-year-old woman. She came in with fatigue, trouble initiating and maintaining sleep, increased difficulty raising her arms, and this sensation of my heart not beating right. Sometimes I feel like it's going to hop right out of my chest.
Palpitations sounds like.
Yeah. She was also losing weight without trying, about 10 pounds. Her cardiac exam revealed an irregular rhythm, consistent with atrial fibrillation, AFib. Pretty common in older adults.
Very common trigger for seeking medical attention.
Right. The rest of her exam showed kind of a slat affect, a fine tremor, some mild muscle weakness, especially in the shoulders, symmetric thyroid enlargement, a goiter, but without tenderness. And that documented 10-pound weight loss.
So putting those pieces together, fatigue, weight loss, atrial fibrillation, goiter, tremor, muscle weakness in a 79-year-old.
Exactly. You can see how these seemingly disparate symptoms, heart issues, weight loss, even maybe mood changes with the flat effect can all point back to the thyroid, especially fitting that atypical or apathetic hyperthyroidism picture common in older adults you mentioned earlier.
Precisely. It's a perfect example of how hyperthyroidism can masquerade as other conditions, particularly cardiac or just aging, in the elderly population. A masterclass in connecting the dots.
Wow, what a deep dive indeed. We've covered so much ground today. From the incredible power of your thyroid hormones to the very specific signs and symptoms of when things go awry, both hypo and hyperthyroidism. We've talked about what to look for, the key tests like TSH and free T4, how it's diagnosed, and the different paths to treatment.
Absolutely. And remember, the body is such a complex system. Understanding the core function of the thyroid really helps connect so many dots. Recognizing the patterns, whether it's the energy drain of hypothyroidism or the overdrive of hyperthyroidism, it empowers you with knowledge. Knowledge that can truly make a difference in your health journey.
Yeah, and I think the key takeaway for me, for everyone listening, is that these conditions are common, they're definitely impactful, but crucially, their symptoms are often reversible with proper treatment.
That's the hopeful message.
Right. This knowledge can really be a shortcut to being well informed about your own health and maybe the health of those around you. So, as we wrap up, here's something to think about. A final provocative thought for you. Given that thyroid disorders often present with such varied, sometimes really subtle symptoms from mood changes to weight shifts to how your hair feels or your energy levels, what other seemingly unrelated health complaints might actually have a deeper hormonal root? A root that could potentially be explored with simple, reliable tests like TSH.
Makes you think, doesn't it?
It really does. Makes you think about how interconnected everything in your body truly is. Thank you so much for joining us on this deep dive today.